So our first speaker today is Dr. Dubraska Diaz-Campos, who's an associate professor at the Ohio State University College of Veterinary Medicine, and I'm excited for her to kick things off, so I will hand things over to her.
Well, welcome everybody, and thank you so much for having me here today. I think I am representing some colleagues that are very interested in antimicrobial stewardship, so I really appreciate the invitation and the chance to be here today. And as my title said, we are going to discuss a little bit of antimicrobial stewardship and use of antimicrobials, but more oriented to companion animals. And then we will discuss some of the pathogens that are a headache for us veterinarians. So some disclosure first. I don't have like important disclosure for this talk. And I want to give a little bit of context and advisory because I have some images that might cause a little bit of disgust to some people. So be mindful. I will try to give you a warning when I'm gonna share one of these graphics, but it's all with good intention. And this is the reality of what we have in our practice. So the objective of today's talk are, number one, I would like to discuss which are the most important pathogens that are important when we think about antimicrobial resistance. And secondly, I would like to highlight the role of the veterinarian and in antimicrobial resistance and antimicrobial stewardship. And then I want to share with you some experiences that we had and other people in the veterinary community, and then give you some tips that you can apply in your practice if I have other colleagues listening here. And at the very end, very briefly, I want to share with you some resources that I'm going to give you some resources during the talk, but at the very end, I have a summary, and then the importance of cross-sector collaboration. So let's get this started because I have too many things to say. And then I'm very excited about this talk. And I would like to start with this case. This is a real case, but this is not a real picture of our dog that we handle in our teaching hospital. So our teaching hospital is a referral practice, so we usually get the worst of the worst. So this patient have TPLO surgery. That means it's a surgery around the knee. It's an orthopedic surgery. So this is an 8 years old, and he went to the referral veterinarian because needed a recheck. And then 8 months after the surgery, Nugget start limping. And then when the referral vet saw Nugget, he say, well, he's an 8 years old, maybe he have osteoarthritis, and some medication for inflammation were prescribed. But what happened is that the owner reported later on that the medication helped a little bit, but he is still limping, and now he's leaking very badly in the site of infection. So his veterinarian, the referral vet, is on radiograph and suspected that the old surgery have maybe an infection, and he prescribed clindamycin, very good antimicrobial stewardship because it's a first-line antimicrobial, and then send it to us for additional workup of this patient. So I'm not radiologist, but from these images, the radiologist said we have osteomyelitis in this patient and also septic arthritis. So our clinicians collected a needle aspirate, sent it to our laboratory, and then we found 5 colonies of Staphylococcus aureus intermedius. The problem is that when we run the susceptibility test, this was the result. So this is becoming more and more common in referral practices. We see these methicillin-resistant staff that are resistant to everything. So we are getting out options to treat these patients. And in cases like this, we are forced to use last resort antimicrobials, or even we will need to do amputation of the limb if that doesn't help. So when we think about multi-drug resistant organisms in veterinary medicine, they cause clinical disease in companion animals and many other animals too, farm animals including, but they can also be reservoirs of disease, and then these pathogens can be transmitted to other pets, other animals, or even humans. And also they can be used as sentinels. Right now we have different surveillance programs where we investigate the presence of multi-drug resistant organisms in veterinary medicine, and that helps us provide information to the international and national surveillance programs. So very briefly here, because I just want to show you, we have the same pathogens. They are most common than maybe you think, especially for the friends that we have today that are no veterinarians. And I'm a microbiologist, so I have to divide this between gram-positive, gram-negative. Plus, I always tell my students, I know it's a pain to learn that, but if you learn the basics, sometimes knowing if it's a gram-positive or gram-negative will help you to do a better empirical use of antimicrobials. So when we think about multi-drug resistant gram-positive, we have Staphylococcus, the same than human medicine, and it can be aureus or Staphylococcus pseudointermedius, as we just saw. We also have infection caused by Enterococcus, and Rhodococcus equi is a pathogen in equine, as the subspecies say. Sometimes we see cases of Mycobacterium. And then when we think about the gram-negative, we have a lot of infections caused by Enterobacterales, Pseudomonas, having report of increased resistance with Campylobacter. And then Pasteurella multocida, very important pathogen in veterinary medicine, and used to be very susceptible to everything, now is showing resistance to some antimicrobials. So an example here, Staph aureus is very common agent in farm animals, sometimes in companion animals too. And we see frequently methicillin-resistant Staph aureus. And the first picture here have a mastitis, inflammation of the mammary gland in a cow. And then in horses, we also see frequently cases of Staph aureus infection, usually associated with soft tissue infections like this one here is an abscess in a horse, and also orthopedic infections, wounds and respiratory infections are also common. And then in companion animal medicine, Staph pseudointermedio is the most common one, frequently associated to folliculitis, superficial pyoderma, or nodules. This is an interdigital nodules or other sort of infections like otitis, urinary tract infections. So we share maybe some same species that cause infection. And then when we talk about Enterococcus, you can see here postpartum uterine infection in farm animals and equine medicine, mastitis. In companion animals, urinary tract infections, very commonly associated with Enterococcus, I will say is one of the top one agents that cause UTIs in dogs and cats, but also occasionally infections in other body sites. And then Pseudomonas aeruginosa, very frequently associated to otitis in companion animal, urinary tract infection. And then it also causes infection in farm animals. So all of this is to tell you we have the same multi-drug resistant agents that we sometimes see in human medicine. About gram-negative microorganisms, maybe some of you know this, but if not, this is just a very short summary. In 2019, the University of Pennsylvania, my colleague Stephen Cole realized that they were having a problem of CRE on patients that were attending their ICU. They were housed in the ICU. And then that was a big news for the veterinary community, because Before that, carbapenem resistance was not really a problem in veterinary medicine, or maybe we didn't know we had that problem, and that this is very well documented. After this first report, we see there are more scientific reports that have been published after this talk. So in this one, it was found that there are some CRE that are shared within 15 veterinary hospitals. So it's persistent in some hospital, which is a problem, and I will show you later why. And then now the most recent publication indicates that the CRE has been shared between humans and pets. So it's not only a problem for human medicine or veterinary medicine, it's a global issue that we are facing. So in OSU, one of the strategies that we have implemented is that we do hospital environmental surveillance, and we will talk a little bit more about that later. So hold that thought for a moment. But one of the agents that we look into in the environment is to monitor if we have CRE in our hospital environment. So this is the graph that shows you the result of our environmental surveillance from January 2018 until March this year. And as you can see here, we found it, and then we clean, disinfect, we clean the environment, and then here we find it again. It was around the ICU. We clean, disinfect, we close the ICU. It was a little bit dramatic because we wanted to prevent nosocomial infections in our hospital. But in 2023, we found this isolate here, and this isolate was characterized as an E. coli, and it was an MDM. And then this E. coli decided to be a guest in our hospital. The most we tried to clean and disinfect, the most we found it in the environment. And it became a nightmare for months for us, as you can see here, because when suddenly we thought, oh, it's completely gone, it showed up again. Thankfully, it's gone now for good. But I want to talk to you a little bit about a patient that we have in our own hospital around November, December, when we were fighting this microorganism from the environment. So this was a 15-year-old cat. It was already pretty old, and it had a lot of comorbidities. It means many other different medical conditions. So it was really immune suppressed. So I started attending our emergency service, and it had a progressive kidney injury. So from October until December, he was in and out of the hospital several times with 37 days in total. And at the same time, we were having that pathogen in our environment, right? Subcutaneous urethral bypass was placed on this patient because the patient have a kidney, he have an urethral obstruction. And then we did several cultures, and all the time this patient was a no growth. Well, sadly, what happened is that in December, we isolated our E. coli, that was the CRE that was in the environment. So even though our personnel, our technicians and clinicians were mindful and trying to do their best, this patient got infected with the E. coli that was in the environment, and here is the pattern of resistance of a CRE. So the only option that we have to treat this patient was amikacin, aminoglucoside, and these antimicrobials can be really nephrotoxic, so we cannot use these for this patient. So as you can imagine, this patient didn't survive, but this is what the veterinary community is facing, and it's a real problem for us. So thankfully here in OSU, we haven't seen any other patient, but there are other veterinary teaching hospitals that are facing patients with this type of infection. So what we can do? And I know if you have attended the previous session, we have talked a lot about antimicrobial stewardship, but maybe we have new people joining today, this webinar series, and how do we do this in veterinary medicine? So very briefly, once again, the definition of antimicrobial stewardship, just in case you didn't attend the previous webinars, coordinated efforts. That's what we need. And then we need to optimize the appropriate use of antimicrobials because what we want to improve patient outcomes, minimize the emergence of antimicrobial resistance, reduce unnecessary costs associated with antimicrobial therapy, and we will talk about that a little bit later. And then we want to be sure the options that we have for therapy are optimal and are going to help our patient. At the beginning of the history, when people start talking about antimicrobial stewardship, people talk a lot about the 5 rights, and we still using that here in OSU. I will tell you in a second when we use it. That means when you are considering using antimicrobials, you need to use the right drug, the right dose, the right duration, the right time, and also have the right diagnosis before you decide to use antimicrobial. Is that always very straightforward? Sometimes it's not and easy, but we will see. One more thing I want to mention is the American Veterinary Medical Association have a lot of information in the website and they publish their core principles. So veterinarians, we should follow these core principles and I'm not going to describe them in detail, but commitments. You can find a champion in your own practice or champions, and then we need to find ways to engage more people. Infection prevention and control is very important. If we don't have infections, we don't have to use antimicrobials. Judicious use, I already talked a little bit about that, but there is a big need of evidence-based guidelines and assessment of antimicrobial use. Education is a pretty big one and very needed. And then we need to evaluate. We need to find ways to evaluate antimicrobial use, what are the barriers, if it's working or not. So in veterinary medicine, there are certain publications evaluating the barriers to antimicrobial stewardship implementation, and I don't have here citations, but I summarize them. And then number one is that many veterinarians have learned how to use an antimicrobial. And now for us to come and say, you know what, we were joking, maybe you shouldn't do it, or you should change it for this. So then antimicrobials is hard, right? Because they will tell you, I have used it for 15 years, 20 years. So changing is difficult. Client expectation is a big one, and it happened yesterday. Our wonderful talk in antimicrobial stewardship in dentistry, they talk about this. The same happened in veterinary medicine. The client will give you a bad review if you don't prescribe their dogs antimicrobials. And then our clinicians also feel fear. They will have patients declining if they decide to withhold or even delay antimicrobial therapy. And then the feeling of the patient can decline, may then use antimicrobials. And then the cost and use of diagnostic is a huge key barrier because they cannot afford, many clients cannot afford diagnostic. So the veterinarian sometimes is just forced to use antimicrobials because that's the only thing can be done. So I'm going to talk now a little bit about what do we do in OSU and give you some tips of what can be implemented in your own practice. And yesterday this was discussed and I was very excited about the integrated model because this is the way we see reduction of antimicrobial resistance. We need to have antimicrobial stewardship and we have been talking about that together with infection control. We will talk, I already talked a little bit about that and I will continue talking, but also diagnostic stewardship. So how this work, the integrated model and the core principles. So commitment is a big one. You need to have leadership support, but also have a champion. In OSU, we are lucky. We have a great team of people, and we have wonderful students that they are not with us right now. But we now have current students, and we are all very excited about antimicrobial stewardship. In this picture, you have Dr. Christy King. She's our PhD student finalizing right now. She has become our infection preventionist expert, and she's giving here a talk to our community practice technicians. And this is Dr. Dimitra Matis, who is currently our director, and she's talking to one of our satellite clinics about giving them an update. And this is some of us working with national groups doing different things that I will mention at the very end. And then this is the micro lab. We all love antimicrobial stewardship. And then we all work together on these endeavors. The only thing that you need in your practice, especially if you are in a small practice, is one champion that decides to start this. So teamwork is the key. The other thing I want to mention is infection prevention and control. As I mentioned before, if we are able to control the infections, we also reduce the use of antimicrobials. So this is very important. It doesn't matter how big or small your practice is, that you have guidance and SOPs and that you train your personnel. Because sometimes we assume, oh, they know, they are RBTs. Well, you need to train them sometime because what is done in a place maybe is different in a different place. So this can be implemented in all levels of veterinary medicine. And then we have here in OSU the hospital environmental surveillance, as I mentioned before, and we monitor multi-drug resistant organisms and also salmonella. Everybody knows salmonella is a big problem for the equine community. So we monitor for these pathogens. And then here in this image, you have one of our students. We sample human contact areas only, so that help us to see, hey, people, you are not washing your hands very well. And here is one of our students that should be graduating as a veterinarian very soon now. He's collecting a sample of one of animal contacts only. And this is our team collecting samples in the equine hospital. And then how this looks like for us, the data, how this looks like. And I'm not gonna go in detail right now with this graph, but in the X, you have the month that we have been doing this surveillance, and in the Y's, you have the numbers of pathogens that we have isolated. And then, as you can see here, we have changed the target organisms over time. Salmonella is one that is always monitored, and then we also look for carbapenem resistant. And as I say, I'm not gonna go in details with this graph, but our message is that if you are working in a big referral hospital, on occasions doing this surveillance help you to understand what's common or uncommon. And then when you have outliers like our carbapenem resistant around the ICU, and that will help you to strategize what you are going to do. After we have our CRE incidents with our patient and in the ICU, we also initiated a patient CRE screening program. So we collect fecal sample in all patients that are admitted into the ICU. We wanted to be sure that if we get a patient that is infected, is this coming from the outside, from the community, or it is a nosocomial infection that we are handling? This is one of the goals of this. And the second one is once we identify a patient that is a carrier, well, we treat this patient with maximum levels of infection control and prevention. So our clinicians and technicians wear proper PPE, and we isolate this patient from other patients because we don't want to get nosocomial infection. And I think it has been effective. We are a very pretty busy hospital, and right now, thankfully, And I'm scared of saying this because when you say they happen, but we have now have issues with CRE as other institutions. So far, until May, we had sampled almost 4,000 patients. Our prevalence is not very high. And we have said for a moment, okay, maybe we shouldn't keep doing this. And suddenly we get a lot of patients that are positive coming from the community. So this is another thing we have done. So if you are working in a small animal practice and you are like, do I really need to do this kind of surveillance? I will say no, because these are a major problem for huge referral practices and veterinary teaching hospital. But if you do community practice, my advice will monitor your patients after you do surgeries or they have visited the hospital. If you start getting post visit infections, maybe contact one institution that can support you and then do a target surveillance. That will be my recommendation. Just to continue talking about infection prevention, hand hygiene is the most effective way to prevent disease transmission. Oh my God, and it's the most difficult things to implement and reinforce in veterinary hospitals. So because we want to increase hand hygiene, our wonderful Dr. Christy King created this flow chart that you see here. It's not a flow chart, it's a informative chart that we share with our community. And this came after we also discussed with UPenn. They have wonderful infection preventionists, Regina, my co-worker Stephen Cole. So we couple a little bit their idea. So and at the same time, we started a hand hygiene audit. I'm not gonna share all the results with you because that will be a little bit embarrassing in some services, but we are working in trying to improve hand hygiene. Can you do this in a small animal practice? Sure, you can train your personnel and ensure people is practicing good hand hygiene, and maybe once in a blue moon you can monitor and do an audit and see, because that way you can provide feedback and then provide educational resources. And as you can see here, we're still struggling in hand hygiene compliance, and as I said, there are some places that even is lower than 23%. So maybe one of our goals for next year is to improve the hand hygiene compliance. So moving a little bit out from infection prevention, now we are going to talk a little bit about judicious use of antimicrobials. So there are several guidelines that are available for you to use in the veterinary side. And if you are a researcher or a public health officer, some global institutions have published guidelines, but then sometimes it's hard for people. Okay, I have this respiratory case. I need to go to the literature, find out. So here in OSU, we say, okay, let's do our own guideline. That also can be used as a strategy to train our students. So this has been a lot of work. We have used international, national guidelines, a lot of literature review, and we put this up and it's available for all of you to use. And the equine and farm animals are now available. And I hope early next year we can have the companion animal available. In the first line guidelines, the Ontario Veterinary College, they also publish their own guidelines. So I will invite you to use them because they will give you a lot of information. In our case, we have guidelines. It will be organized by by diseases. Like I want to know for pyoderma, so you can look pyoderma. And then we have the pathogens. Oh, this report said I have, let's go extreme, Yersinia. What should I do? And then you can find all the information about Yersinia. And then when you go to the antimicrobials, you can find all the information of antimicrobials from dosing up to potential side effects. So this is there for you for your use. So when we think about judicious use, we are like, okay, what that really means? And this is my summary. Number one, we should try to avoid using antimicrobials just in case, which, as I mentioned before, is very hard, and there are some barriers around that I think we need to overcome with time. I always say, can you use topical therapy, especially for pyoderma? If you review the last guidelines that were published for pyoderma in veterinary medicine, it say even if you have a methicillin-resistant staph, use topical therapy instead of systemic therapy. So topical or regional therapy are ideal if that's a possibility. And then, are we using empirical antimicrobials? If that's the case, let's have at least one diagnostic test. And then I know for general practitioners, this can be hard, but maybe sometimes a cytology can guide you to discover what's the best antimicrobial that you can use. And then we always say, let's use first-line antimicrobials because these are the best option for many cases. But what this really means? What means first-line antimicrobials in companion animal medicine? So right now I'm gonna take you out of the United States for a second, and we are gonna go to the Federation of Veterinarians of European countries. And I'm not gonna go in detail of this slide because we don't have that time, but they have classified 4 categories of antimicrobials. And then they have the category A are the ones that a veterinarian should never use uh, only under exceptional circumstances, and I will tell you which one are those. And then we go to the prudence category where they should be the first line if needed, but they never say, oh, let's use antimicrobials. Even the low line should be used with a lot of prudence, right? So what does really mean how this looks like? And once again, I'm not gonna read all of this for you, and you will have the slides. But when they say avoid in this category that never use, they have carbapenems, linezolid, vancomycin, fosfomycin. They even have mupirocin in this category, and many more. In category B, restrict, they have third and fourth generation cephalosporins, and we use third generation cephalosporin a lot in veterinary medicine, and they also have the fluoroquinolones. We use it then a lot. And then in the prudence category, they have the beta-lactams, basically the first line beta-lactam, the aminopenicillins, and then tetracycline, sulfas, metronidazole. So that means that in this country, they are more strict about antimicrobial use in companion animal medicine, and they basically use only antimicrobials in the prudence category. So what happened in the US? In companion animal, we really don't have a strict regulation on antimicrobial use, and I don't think we will have it. The American Veterinary Medical Association, they support they support the WHO classification, and they said veterinarian maybe should use this as a risk management tool. And they really encourage judicious use of antimicrobial, but we don't have a strong regulation of what antimicrobials we should use or not. However, I can tell you that I trust most veterinarians are trying to do their best. We just need a little bit more of education in what antimicrobials should we consider, the ones that are low risk versus the ones that are high risk. So we went from European countries to national recommendations, right? And now let's bring you to OSU. What do we do here? So we created an SOP for use of last resource antimicrobials in collaboration. And we use the WHO aware classification system, and then we have the full access where we tell clinicians you don't need to have an AST and you don't need to talk with nobody else. You use your antimicrobials. And then you have the watch category where we say, well, we recommend maybe you should have a susceptibility report before you use these antimicrobials. That means maybe the enrofloxacin, the third generation cephalosporins, and then collaborate. Like if it's a resident, maybe ask your supervisor what is the best that you can do. And then we have the reserve category where we have our last resort antimicrobial carbapenem, linezolid, vancomycin. And for this to be approved, we need to have, and I keep moving this before time, we need to have an antimicrobial susceptibility test and then a consult. What means a consult? So once the clinician receive the report from the laboratory, sometimes they reach out to our group, or the microbiology lab will directly reach out to our group and say, hey, for you to know, we got this pathogen in this patient, most likely we will need a consult for this. And then the decision is made in collaboration, and then we decide the right dose, right duration, etc. The 5 rights we already discussed. And on occasions, to be honest, our recommendation is like, you really don't need to use this antimicrobial. It is up to students to do it because this is not a mandate, but we just provide a recommendation. Or let's use topical instead of start with systemics and see how that happened. And I have to say, our clinicians are wonderful. They love to collaborate. They do a lot of consults. So we work together very, very well. If you are in private practice and you need a friend to talk about your cases, we are available, and other many groups are enthusiastic to talk about your cases if that's needed. So far, we have talked about antimicrobial stewardship, we have talked about some things of infection control, and very, very briefly, because we don't have the time to go deep into diagnostic stewardship, we will cover diagnostic stewardship in companion animal because we have these 3 elements, right? And for doing this, I want to share with you a case from Washington State University when I worked there. And this is going to be very fast, so bear with me here. This is a cat that was 6 years old, and it was a fighter. You know, cats like to go out and get into troubles. And then at the end of October, he got back home with bite wounds. So he was treated with antibiotics. We don't know which one was used, and most probably was empirical because that's what we do when we have a cat fighting. And then, as you can see here, from the end of October to the end of December, the cat really got sick. It was lethargic, lost weight, have fever. So the referral beds have indicated have multifocal to diffuse regions of alopecia, and this happened in the dorsum, close to the tail base, and tendon in the back, basically. And then the veterinarian decided to do cytology, and then this referral vet collected culture swabs and requested aerobic culture and submitted one of the samples, collected also tissue, and this tissue was submitted for biopsy. If you talk to a microbiologist, we will tell you we want tissue. We don't want a swab. And I will tell you in a second why. So the cytology results indicate there were some microorganisms there that were filamentous, but they were too small for being a fungi. But they did acid fast, and if you are a veterinarian or a human doctor, you are like, oh, I know what was the problem there. But the thing is that the aerobic culture was a no growth. I will tell you, most of the laboratories know that if you are suspecting nocardia, which was the problem for this patient, sometimes we need to put a plate in a regular incubator and not a CO2 incubator. But looks like the communication was not very good. So this is not a real image from this patient, but I wanted to have it here for you. So I stole this from Dr. McKinsey Lund. This is a similar cytology that you will see when you have a nocardia case. And the cytology say we recommend biopsies to be submitted for mycology and bacterial culture. The histopathology report also saw intralesional bacteria. So what happened after that in January? The wounds really didn't improve. And then the vet decided to start the patient on marbofloxacin. And then again, 10 days later, no improve was observed. And then at the very end, the owner decided euthanasia. So if you are sensitive, please don't look at the next slide that I'm gonna share with you. But then the veterinarian was really sad and upset about this patient because it was like, it was just a bite, why this happened. And then decided to send the patient to Washington State University for an autopsy. And this is what we receive, right? As you can see here, this is a classical presentation, ulcerative tissue, ulcerated tissue here, and then the histopathology showed these beautiful colonies aggregated here, and these, we identify these as nocardia. So can we say, oh, the veterinarian failed of not submitting the biopsy to the lab? Maybe, but the diagnostic process is very complicated. So my advice to you, communicate with your lab, discuss with colleagues. And the other problem that we have in veterinary medicine, and maybe this is what happened in this case, because actually the history say the tissue was collected and put on hold for later on, but maybe when the veterinarian wanted to change and send these for culture was impossible due to financial restrictions. So the WHO have some definition for diagnostic stewardship, and then is the coordinated guidance and intervention to improve the appropriate use of microbiological diagnostic. Because at the very end, what the laboratory put in the report is what's going to guide approach to use of antimicrobials. So that's why diagnostic stewardship is a very important piece in the fight against antimicrobial resistance. So specimen collection is very important. The laboratory work in pathogen identification and providing accurate reports is very important to guide patient treatment. If you want to learn more about diagnostic stewardship, these are publications from 2024, but there are a myriad of diagnostic stewardship and the importance of diagnostic stewardship for antimicrobial stewardship. Some of them are review articles, some others are directed for the laboratories, and then you have real scientific research done demonstrating the importance of diagnostic stewardship. So, to finalize diagnostic stewardship, there are a lot of barriers too in veterinary medicine, clinical and workflow. It's hard in practices where they are very, very busy. They work with different laboratories. So that becomes sometimes a barrier. Sometimes they don't have the time to even do a cytology. Financial constraints in veterinary medicine, we don't have the same structure of insurance that we have in human medicine. So money is a big problem for the proper diagnostic stewardship. Knowledge and training. I think we need to train our clinicians better in sample submission and test selection and interpretation. Laboratories have a lot of needs that I'm not going to discuss right now. But then the main message here is talk to your lab. We can guide you in what's the best to do with complicated cases. There is a recent publication that we put together to guide the veterinarians in how to use the microbiology laboratory, what's the role of the lab, and what's the best sample that you can submit based on body sites or different diseases. So I invite you to review this article. And we also published this one recently, and we demonstrated that most likely the reports of susceptibility have a huge impact in what the what the veterinarian use when deciding antimicrobial therapy. So let's take a peek to these two articles. They will be very illuminating for you if you practice veterinary medicine. So some key resources and opportunities that are available. So for the veterinarians attending this talk, there are global guidelines for the responsible use of antimicrobials. And these are targeted for companion animal medicine. Sometimes I have talked to some clinicians and they are like, what guidelines are you talking about it? And I understand because sometimes they don't have the time to do a lot of literature search. AHA also have some interesting guidelines, so I will recommend to use them if you have the need. And as I say, we have put a lot of these recommendations together in our first line app, so feel free to use them. Something new that is happening related with infection control and prevention, and I'm very excited about this. Now we are working with APIC. They gave us, now we have a small working group there with wonderful people that have initiated this. So I think they will have a lot to bring to the whole community. And then I'm very excited to be part of CAMS. This is the Companion Animal Antimicrobial Stewards group. We have done so far two different forums, workshops, sorry, and we are working together with the International Society, ISCE, of Companion Animals. So we have put together a series of educational webinars, and this is something that's going to continue happening. So join us, and I recommend you look at the webinars that are happening and will be happening in the future. For friends interested in diagnostic stewardship, the Clinical and Laboratory Standard Institute have a whole committee focused in animals. So we need more and more volunteers. I have been chairing this committee since 2023, and I have one more year to go. But we have different working groups. It's a fascinating environment. So if you have some interest in diagnostic stewardship and improving antimicrobial susceptibility testing and work with us in education, you are invited. So these invitations are also open to our government attendance because we need a lot of help. If you work in general practice and you are interested in how do I start antimicrobial stewardship, there are tons of resources. You can go to the ABMA website and they have some instruments like this. They have a lot of good information, and this is a checklist for antimicrobial stewardship. And as I said before, it doesn't matter if you work in a huge veterinary referral hospital, you can do antimicrobial stewardship in even a small practice. As my friend and colleague from the University of Minnesota said, you don't need to do a whole implementation. You just decide in one or two activities by the time. So if you go to the University of Minnesota, they also have this handbook of antimicrobial stewardship in companion animals. That's wonderful. So I invite you to visit that. Our own website have a lot of good information and resources about antimicrobial stewardship. And here we have a publication that explains how we started this program. So feel free to take a peek of that. And then one of the things that get me very, very excited, and I would like you all using this. We have put together, this was an effort with an FDA, the VetLearn grant. They supported us to create more than informational videos about antimicrobial resistance and antimicrobial stewardship implementation in veterinary medicine. So if you have a hard time communicating with your clients about what is antimicrobial resistance or why you decided not to give an antimicrobial to your patient, you have some videos here that are towards to owners. So use them. We have some based on clinical conditions. So if you are like, I don't have the time to read this whole ISCE guidelines, we have for urinary tract infection, respiratory infection in cats, wounds. So we have make efforts with our clinicians here, our experts, plus a lot of investigation in resources and guidelines to put these videos together. So feel free to use them because we don't want these videos sitting just in YouTube and nobody using them. And then just to finish right now, I just want to finish with this phrase. Antimicrobial resistance doesn't respect species boundaries. Animals, humans, and the environment are interconnected reservoirs and transmitters. So I want to thank the organizers of these webinar sessions because having a day dedicated to the veterinary community is great. Sometimes we don't have a voice. We are very important. We can give you bad antimicrobial resistant agents, and then we all need to work together in the concept of One Health. And then I want to thank our entire group, and I was planning to put a group picture, but this is us. So this week we have one person creating the posters that are here. One other person from our team took this poster that we have here and put this table. I created an email that we share with our entire veterinary medical center, thanking them for their commitment to antimicrobial stewardship. So instead of a picture, I was looking at this image yesterday, and I want to thank my team because these small things happen because we care and we work very hard for this, even when we don't get extra pay for this. I also want to thank the BNC leadership and our clinicians because they are awesome. And sometimes even when we don't agree, they love everything that we do and they are big fans of our job. And then I have a lot of collaborators, internal and outside the OSU in different groups, and all the enthusiasts on antimicrobial stewardship in veterinary medicine. And then I will be happy to take questions if you have them.
Thank you for that wonderful presentation. I can attest that I learned a lot while it, and I'm sure that our audience did too. We do have a request in the chat. If you could go back to the slide that had the 5 R's on it, I believe they're wanting to look at that again, and then we can jump into questions.
This one.
Perfect. And I wanted to ask, I believe it was your first patient case that was the cat with the carbapenem-resistant E. coli. Were you able to offer definitive therapy for that organism? Or from a pharmacist perspective, I'm curious what you would use to treat. Are there any options at this point?
No, so we have a wonderful pharmacist working with us. This is Dr. Ricky Horn, so she's part of our team. And as I mentioned before, when we do consultation for these cases, decisions are not made for only one person. So we always discuss cases between the pharmacist, the microbiology team. Most likely, we like to involve the clinicians involved in the case because sometimes they have recommendations or they have additional information about the case or what's happening that we don't know. So in this case, was a real problem. We try amikacin even when the cat have kidney issues, but it didn't work. As you can imagine, very nephrotoxic. So that's the main reason. And the patient have some other comorbidities. So yes, we had to let that cat go. one of the things with carbapenem-resistant bacteria, and one of our students is working in the analyzing and finding out the risk factors and comorbidities for us is one of the biggest ones. So stay tuned. We are planning, we have two publications in the pipeline. One is our response for CRE that Dr. Christy Kim put together and was recently accepted in the Journal of Veterinary Internal Medicine because we want to share our experience with CRE in the environment and this patient and what was our response. I have been told for other colleagues, like, you have been lucky, you don't have patients. And I think because we are going to the extreme, we are doing a lot of prevention to avoid having patients with nosocomial infections. And then we have the second one, analyzing what we consider risk factors. And then I'm talking too much to your question. Ami
No,
case.
that's okay. I enjoy hearing what you have to say for sure. And I really appreciate your emphasis on infection prevention as well, because that really is so essential. And I think just to kind of piggyback off of what I asked, realizing we only have a few minutes left, and I'm kind of opening a can of worms. So in humans in that situation, we have a few different carbapenem-based options that have a beta-lactamase inhibitor. So I recognize that the pharmaceutical companies likely will not be pursuing animal studies with those drugs. Is that something that you and veterinary academia will then look into, or is there kind of a process to get those human drugs and evaluate them in animals? I realize I might be opening a can of worms there.
Oh, it is. To be honest, we try not to use those antimicrobials in veterinary medicine at all. And one of the things that we face, like recently, we have a question like, can we use vancomycin on this patient? And it will be equivalent to what you just asked. This specific new drugs is like, we don't know really what dose, if we will see side effects on these patients or not. So it gets very complicated. And if you talk to our colleagues in European countries, I was talking with some of them recently, and they just say, we have never used linezolid. You in the US use linezolid all the time. We have never used it. And then I made the question, like, what do you do when you have a patient that is gonna lose their leg? Like the first case that I showed you, right? You have a joint infect, septic arthritis, osteomyelitis. The owner doesn't want that leg to be amputated, and the owner already has spent like thousands and thousands of dollars in this surgery. How can I come and say, you know what, we are not using linezolid on this patient, and then their solution is to just cut the leg? So it is very complicated, and they were like, well, that's what we will do, we will amputate the leg. And I'm like, I don't know. So it gets very complicated.
Understood. Well, thank you for your time and your expertise today. I really appreciate it.